بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. I'm Dr. Hambacha, PhD Diagnostic Ultrasound Associate Professor. Today we'll discuss about cardiomyopathy and the role of echocardiography and the evaluation of cardiomyopathy and cardiac dysfunction, heart failure. Myocardium is responsible for the contractile function of the cardiac pump composed of cardiomyocytes. The heart muscle has distinctive cellular and physiologic features, allowing it to generate force to maintain adequate tissue and organ perfusion throughout the body. Echocardiography is not only depicting the heart morphologically, but it also useful in the evaluation of heart function. The morphological changes that occur during cardiac function can be evaluated with real-time echocardiography. The impairment of the cardiac function is called myocardial dysfunction or cardiomyopathy. The term cardiomyopathy means a disease of the heart muscle or myocardial dysfunction. In strict sense, the term should only be applied to a condition that has no known underlying cause. In that case, it is known as in idiopathic cardiomyopathy. However, the term has, to popular usage, been extended to include conditions where there is an identifiable cause. Example of such conditions include hypertensive, ischemic, alcoholic, and diabetic cardiomyopathy. Cardiomyopathy has broadly been divided into three groups: dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. Disease of the heart muscle characterized by enlargement and dilatation of one or both of the ventricle are termed as dilated cardiomyopathy or DCMP. It is characterized by impaired contractility and left ventricular ejection fraction less than 40%. The percentage of blood that is ejected during systole out of the heart of the total blood that is present during diastole in the left ventricle. On M-mode and two-dimensional echocardiography, there is dilatation of the forecardiac chamber, particularly of the left ventricle, which thereby assume a more globular shape. The left ventricle end diastolic dimension exceeds 52 mm, while its normal range is from 36 to 52 mm. Apart from all that, reduced left ventricular wall thickness, reduced systolic thickening, reduced amplitude of the wall motion is observed. The reduced left ventricular wall motion is generalized or global rather than regional. That's why this is known as global or generalized hypokinesia. The left ventricular wall are thin. There may be mild hypertrophy, which is inadequate for the degree of left ventricular dilatation. Left atrial enlargement occur due to stretching of the mitral annular ring, which leads to functional mitral regurgitation. There is reduced motion of the interventricular septum and left ventricular posterior wall. The ventricular dimension during systole and diastole, left ventricular and systolic dimension, left ventricular and diastolic dimension are increased due to a global or generalized hypokinesia. The systolic excursion of the interventricular septum and left ventricular posterior wall are reduced. For the same reason, the left ventricular diameter and end diastole and end systole is increased. Reduced fractional shortening Fs and ejection fraction, left ventricular ejection fraction LVEF. The ejection fraction is also is low, but the cardiac output may be normal due to compensatory tachycardia. Increased size of left ventricular cavity, reduced motion of the interventricular septum and left ventricular posterior wall, and increased A-point septal separation, reduced excursion of the mitral leaflet. So here you can see this is an M-mode image, and you can see the anterior and posterior wall of the left ventricle during systole and diastole. So here you can see the interventricular septum, which is this one, and the posterior wall, which is this one. This is systole and diastole, and this is and uh, sorry, this is a left ventricular systolic dimension, and this is left ventricular diastolic dimension. So here you can see during diastole, the left ventricle enlarge in size, and in systole it become smaller. And here you can see this is a distance between the anterior mitral leaflet and the interventricular septum. So this is also known as E point. So this is E point. So E point to septal separation. And now here you can see there is a prominent increase in the A point to septal separation. And then reduce excursion of the mitral leaflet. This is excursion. This moment of the mitral leaflet, this is excursion. So this become reduced, right? Due to global or generalized hypokinesia, indices of the left ventricular systolic function are reduced, which we have already discussed, and the ventricular dysfunction. Increased E point to septal separation we have discussed, and you can see in this image. It is the distance between the farthest posterior excursion of the septum and the E point of the anterior mitral leaflet AML. The normal E point to septal separation is not more than 5 mm. The E point to septal separation is reduced in hypertrophic obstructive cardiomyopathy due to systolic anterior motion. We will discuss it later on in this lesson and this session of the anterior mitral leaflet. Measurement of endpoint to septal separation lacks utility in the presence of mitral valve disease, in which case free motion of the anterior mitral leaflet is already impaired. Reduced anterior swing of the aortic root during a left atrial filling. A normal value is more than 7 mm. Reduced aortic valve cusp separation and systole, which is normal more than 15 mm during systole, with the premature closure of the aortic valve, which is shown in the next figure. So here you can see this is an aortic valve, and you can see the systolic opening and diastolic closure of the aortic valve. Reduced mitral valve anterior leaflet excursion and diastole. Normal value is more than 20 mm with rapid upstroke and downstroke. All the above are signs of reduced cardiac output associated non-specific finding in diastolic cardiomyopathy are small pericardial effusion, left ventricular thrombus. Functional mitral and tricuspid regurgitation occurs due to stretching of the atrioventricular ring as a consequence of ventricular dilatation. Differential diagnosis of dilated cardiomyopathy are it may be extremely difficult to differentiate dilated cardiomyopathy from the following conditions, such as severe mitral regurgitation with left ventricular dysfunction, ischemic cardiomyopathy, severe mitral regurgitation with left ventricular dysfunction, severe organic mitral regurgitation with volume overload, and left ventricular dysfunction can mimic diastolic cardiomyopathy with functional mitral regurgitation due to annular stretching. So this is a differentiation between a dilated cardiomyopathy and ischemic cardiomyopathy. So there will be hypokinesia and and dilated cardiomyopathy as well as in ischemic cardiomyopathy. But in ischemic cardiomyopathy it will be regional, but there in diastolic cardiomyopathy it will be generalized or global. Wall motion and perfusion unmatched. And here, in the case of ischemic cardiomyopathy, there will be matched wall motion and perfusion. If there is increased perfusion, blood flow perfusion in the wall of the heart, there will be a movement in the wall. But if there is no blood flow in the heart wall, there will be no flow. Dyskinesia, it is not seen in the dilated cardiomyopathy, but in the case of ischemic cardiomyopathy, there will be dyskinesia. In the cases of hypokinesia, there was decreased movement, but in the case of dyskinesia, there will be difficulty in the movement. Right ventricular involvement often seen in dilated cardiomyopathy, but in the ischemic cardiomyopathy, it will be regional. So, right ventricular involvement is so rare. Organic mitral regurgitation where left ventricular diastolic dysfunction is suggestive if there is one of the following features: mitral leaflet thickening, prolapse or leaflet. Leaflet flail refer to the abnormally increased leaflet mobility of the anterior atrioventricular valve associated with valvular prolapse and systolic excursion of the leaflet tip or edge into the atria. A history of a long-standing pensystolic murmur. Ischemic cardiomyopathy, dilated cardiomyopathy can closely mimic ischemic cardiomyopathy with certain subtle differences discussed in the previous table in the comparison. There is global hypokinesia in the dilated cardiomyopathy, while in the ischemic cardiomyopathy, there was local or regional hypokinesia. At least there will be one region of the left ventricular movement normally. If there is patch involvement and dilated cardiomyopathy, the regional motion abnormality don't conform to atrial distribution. On the other hand, in ischemic cardiomyopathy, regional wall motion impairment abnormality conform to coronary perfusion territories. Right ventricle is often involved in dilated cardiomyopathy, but relatively spared in the case of ischemic cardiomyopathy. Dyskinetic area and aneurysm are features of ischemic cardiomyopathy. Causes of the dilated cardiomyopathy are including idiopathic, post-viral, alcoholic, diabetic, peripartum, nutritional, or drug-induced. Causes of the large left ventricle in adult. So if you observe a left ventricle, a large left ventricle in the adult individual, so it could be due to dilated cardiomyopathy, anterior myocardial infarction, ischemic cardiomyopathy, left ventricular volume overload, for example, mitral regurgitation, aortic regurgitation, or PDA. Mitral regurgitation, aortic regurgitation are patent ductus arteriosus, PDA, patent ductus arteriosis. Left ventricular pressure overload can be in the cases of aortic stenosis or generalized hypertension. Causes of the large left ventricle in infant, congenital cardiomyopathy, coarctation of the aorta. So, in the case of coarctation of the aorta, there is a birth defect in which part of the aorta is narrower than usual. If the narrowing is severe enough and if it is not diagnosed, the baby may have serious problems and may need surgery or other procedures soon after birth. Anomalous left coronary artery arising from the pulmonary artery, that could also be a cause of the left ventricle enlargement. Restrictive cardiomyopathy. By definition, restrictive cardiomyopathy is the impairment of the heart relaxation. It refers to a set of changes and how the heart muscle function. These changes cause the heart to fill poorly, which is more common, or squeeze blood, that is least common. Sometimes both problems are present concomitantly. In the cases of restrictive cardiomyopathy, the heart muscle are of normal size or slightly enlarged. Most of the time, it also pumps normally. However, it doesn't relax normally during the time between heartbeat when the blood return from the body during diastole. Although the main problem is abnormal filling of the heart may not pump blood strongly when the disease progress, and then its mean systole will also be affected. The abnormal heart function can affect the lungs, liver, and other body system. Restrictive cardiomyopathy may affect either or both of the lower heart chamber, for example, ventricles. Restrictive cardiomyopathy is rare condition. The most common cause are uh, amyloidosis, and scarring of the heart from an unknown cause. It also can occur after a heart transplant. Now, echo features of the restrictive cardiomyopathy, an M-mode ultrasound and two-dimensional echo. You can see thickening of the left ventricle and right ventricle free wall and the interventricular septum. The thickness of the left ventricular posterior wall and interventricular septum in diastole exceeds 12 mm, and that of the right ventricle free wall is more than 5 mm. Bright echogenicity of endocardium with patches of speckling are more mottling in the myocardium. Infiltration of amyloid into the interventricular septum produces a speckling ground glass appearance. This is an apical four-chamber view which show thick and bright septum reduce size of the ventricle, dilated right and left atrium. You will observe reduce internal dimension and cavity size of the left and right ventricle with cavity obliteration at left and right ventricular apex. The left ventricular end diastolic dimension is reduced to less than 35 mm. Normal is 36 to 52 mm. Mild impairment of the left ventricular systolic function with reduced interventricular septum and left ventricular posterior wall thickening and inward motion. Thickening of the mitral and tricuspid leaflet, dilatation of the right atrium and left atrium, ventricular thrombus, and pericardial effusion. Mitral tricuspid regurgitation, mitral regurgitation and tricuspid regurgitation due to thickening of the mitral valve and tricuspid valve leaflet. Impairment of the left ventricle and right ventricle diastolic function with a slow relaxation pattern, A taller than E, or restrictive pattern, very tall E seen on mitral valve inflow spectral tracing. So here you can see this is a schematic diagram. You can see normal, the slow relaxation pattern and the restricted pattern. And here you can see these are echocardiographic images of normal pattern. Here you can see E is taller than A, and slow relaxation pattern where A is taller than E, and here restrictive pattern where you can see a large E but almost negligible A. A few differential diagnoses of restrictive cardiomyopathy are mentioned here. It may be difficult to differentiate a case of restrictive cardiomyopathy from constrictive pericarditis on the basis of echo finding. Often cardiac catheterization is required. The differentiation between restrictive cardiomyopathy and constrictive pericarditis is important because the management plan is based on echo findings and different management plan is selected for both of them. The features which are mentioned below are observed only in the case of restrictive cardiomyopathy and not in constrictive pericarditis. Thickening of the ventricular wall, restriction of ventricular cavity size, impairment of left ventricular systolic function, mitral and tricuspid regurgitation, dilatation of right and left atrium. Restrictive cardiomyopathy needs to be differentiated from apical cardiomyopathy, a subtype of hypertrophic cardiomyopathy, where the hypertrophy is confined to the apices of the ventricle with obliteration of the ventricular cavity. Restrictive cardiomyopathy from apical cardiomyopathy, the right and left atrium are enlarged. The only other cardiac condition in which both atria are enlarged with the normal or small ventricle is mitral stenosis with pulmonary hypertension and secondary tricuspid regurgitation. And dilated cardiomyopathy, there is enlargement of the four chambers of the heart. A few most important causes of restrictive cardiomyopathy are mentioned below. Idiopathic restrictive cardiomyopathy, endomyocardial fibrosis, lobular hypereosinopalia, which is characterized by hypereosinopalia, inflammatory thrombotic, and ultimately fibrotic involvement of the heart leading to multiple complications including valve involvement, thromboembolic phenomena, and heart failure. Uh, Carcinoid syndrome. Carcinoid syndrome refer to a set of symptoms tied to tumor called carcinoid tumor and the release of hormone serotonin. Carcinoid are a type of neuro uh, a neuroendocrine tumor found in the cell that resemble nerve but which can also release hormone. Many carcinoid tumors are benign in nature, non-cancerous, but they can also turn malignant, become cancerous. They develop most often in the gastrointestinal tract, but can also form in the lungs and in the airway. Occasionally, they develop in other areas of the body. Symptoms include flushing, diarrhea, wheezing, and spider veins. Myocardial infiltration due to amyloidosis, a rare disease that occurs when a protein called amyloid build up in the heart wall. Sarcoidosis is chronic disease of unknown cause characterized by enlargement of lymph nodes in many parts of the body and widespread appearance of granulomatous derived from reticuloendothelial system. Malignancy can also cause restrictive cardiomyopathy and hemochromatosis is a disorder in which the body can build up too much iron in the skin, heart, liver, pancreas, pituitary gland, and joints, which leads to restrictive cardiomyopathy. Glycogen storage disease. It is a rare metabolic disorder where the body is not able to properly store or break down glycogen, a form of sugar, glucose. Glycogen storage disease affect the liver, muscle, and other areas of the body depending on the specific type. An eyeball assessment of observe small left ventricle. So what will be the cause of that small ventricle? There are a wide range of cause of small left ventricle, but the most important are mentioned over here: restrictive cardiomyopathy, hypertrophic cardiomyopathy, hypertensive heart disease, aortic valve stenosis, ventricular thrombus, intracardiac tumor, and athlete's heart. First of all, we should know the hypertrophic cardiomyopathy. So, hypertrophic cardiomyopathy mean a heart affection caused by cardiac muscular hypertrophy. It is a condition affecting the left ventricle, which is the main pumping chamber of the heart. The wall of the left ventricle become thick and stiff. Over time, the heart can't take in pump out enough blood during each heartbeat to supply the body's need. Uh, what is our responsibility in the evaluation of hypertrophic cardiomyopathy? On echocardiography, if we apply a mood and two-dimensional echo, then we will observe asymmetric septal hypertrophy. There is hypertrophy of the interventricular septum to a greater extent than that of the left ventricular posterior wall. Thickening of the interventricular septum is confined to the base of the uh, impinges on the left ventricle outflow tract, at the base of the aorta. The ratio of the interventricular septum to left ventricular posterior wall ratio exceeds 1.5. Asymmetric septal hypertrophy (ASH) is observed in 60% of the cases of hypertrophic cardiomyopathy, while 30% shows symmetric ventricular hypertrophy, and 10% cases the hypertrophy is confined to the apices of the ventricle, for example, apical cardiomyopathy. The thickened interventricular septum show bright echogenicity with the speckling uh, in the myocardium due to myocardial fiber disorder. There is reduced interventricular septal motion with the vigorous excursion of the left ventricular posterior wall. The left ventricular cavity appears small. Systolic anterior motion (SAM) of the anterior mitral leaflet during mid-systole, the AML move anterior to cooped with the septum. This occur due to the ventral effect caused by high velocity in the left ventricular outflow tract. In parasternal lung axis view, the heart muscle appear asymmetrically hypertrophied, include septal hypertrophy. Here you can see this is a apical four-chamber view showing hypertrophy of the left ventricular apex. So again, it is an asymmetric muscular hypertrophy. M-mode scan of the mitral valve shows systolic anterior motion (SAM) of the anterior mitral leaflet, which is shown over here with the SAM, right? This one. Systolic anterior motion (SAM) occur during the a later stage of the systole when the left ventricular cavity size becomes smaller. SAM cause dynamic left ventricular outflow tract obstruction. Therefore, the term hypertrophic obstructive cardiomyopathy is more appropriate. If the left ventricular outflow tract obstruction is not demonstrable, the term used is idiopathic hypertrophic subaortic stenosis. Left ventricular outflow tract obstruction may be present at rest or become more pronounced following provocation. The duration of contact between the anterior mitral leaflet and the interventricular septum correlates with the severity of the left ventricular outflow tract obstruction. Provocation may be provided by prolonged standing, isoolumic exercise, for example, hand grip, Valsalva maneuver, or sublingual nitrate. All these methods reduce left ventricular size and thus increase the degree of left ventricular outflow tract obstruction. Dynamic left ventricular outflow tract obstruction during the later part of the systole cause mid-systolic aortic valve closure and late systolic flattening of the aortic cusp. M-mode scan of the aortic valve shows mid-systolic closure and late systolic flattening. So you can see we have already shown you the M-mode scan of aortic valve. So there were no fluctuation in that normal scan, right? So here you can see the opening of the aortic valve is now there is a variation or fluctuation in the valve, aortic valve, right? On continuous wave Doppler, there is increased peak flow velocity across the left ventricular outflow tract. Pulse wave Doppler with the sample volume and the left ventricular outflow tract show the increased velocity to be proximal to the aortic valve. The high velocity jet has a characteristic concave appearance with the peak velocity coinciding with the peak SAM and mid systole. Normally at peak and early systole. There are features of left ventricular diastolic dysfunction due to myocardial hypertrophy with an abnormal transmitral inflow, spectral trace, A wave taller than E wave. Mitral valve regurgitation is frequently associated with left ventricular outflow tract obstruction. So here you can see this is a continuous wave Doppler waveform showing a concave high velocity jet in the left ventricular outflow tract proximal to the aortic valve. Differential diagnosis of hypertrophic cardiomyopathy and interventricular septum, left ventricular posterior valve ratio of 1.5 or greater indicate hypertrophic cardiomyopathy. A ratio between 1.3 and 1.5 is observed, and hypertension with left ventricular hypertrophy, aortic stenosis with left ventricular hypertrophy, septal infiltration. And the cases of restrictive cardiomyopathy. Localized subaortic bulge is in the basal part of the interventricular septum. Sigmoid septum is a normal finding in the elderly individual and should not be misdiagnosed for hypertrophic cardiomyopathy. Reduced interventricular septal motion with the vigorous left ventricular posterior wall excursion is a feature of hypertrophic cardiomyopathy. Reduced interventricular septum motion is also observed in dilated cardiomyopathy and an old myocardial infarction with the following differences. The left ventricular posterior wall is also equally hypokinetic in dilated cardiomyopathy. The left ventricular posterior wall show hypokinesia in old septal MI. Systolic anterior motion SAM of the anterior mitral leaflet is also observed, and mitral valve prolapse, anterior blocking of the anterior mitral leaflet, hyperdynamic circulation, vigorous excursion, pericardial effusion, pseudo-SAM, systolic anterior motion during swing. Mid-systolic aortic valve closure occur in hypertrophic cardiomyopathy due to dynamic left ventricular outflow tract obstruction. Premature systolic aortic valve closure is also observed, and a subvalvular aortic stenosis, mitral regurgitation, left ventricular ejection into a left atrium, VSD, left ventricular ejection into right ventricle, and dilated cardiomyopathy, reduced left ventricular output. The peak flow velocity across the left ventricular outflow tract in hypertrophic cardiomyopathy can be differentiated from the valvular aortic stenosis by the following features. On pulse wave Doppler, maximum velocity is proximal to the valve. The flow velocity has a typical concave pattern, which we have already discussed during systole, which was a concavity during systole. Left ventricular diastolic dysfunction and hypertrophic cardiomyopathy can be differentiated from that due to restrictive cardiomyopathy by the presence of the asymmetrical septal hypertrophy and systolic anterior motion, left ventricular outflow tract obstruction, and early aortic valve closure. The high velocity jet across left ventricular outflow tract and hypertrophic cardiomyopathy need to be differentiated from the adjacent jet of the mitral regurgitation, which often coexist. The timing of the systolic velocity and concave appearance of the jet are classical feature of hypertrophic cardiomyopathy. Based upon the location of the hypertrophy and presence or absence of the hemodynamic effect, the hypertrophic cardiomyopathy can be classified into these types. Location of the hypertrophy could be symmetrical or asymmetrical. So asymmetrical septal hypertrophy and symmetrical left ventricular hypertrophy. And the cases of hemodynamic effect, it could either be obstructive or non-obstructive cardiomyopathy. In the case of hypertrophic obstructive cardiomyopathy, there will be blood flow impairment in the left ventricular outflow tract. Idiopathic hypertrophic subaortic stenosis, and this is another type of hemodynamic type of cardiomyopathies. It was all about the cardiomyopathies and the role of echocardiography in it. So thank you very much. See you in the next lecture.